I'm Caroline Duquette from Nossum University, and I am pleased today to be presenting the study Emergency Department Boarding Time and its Association with Functional Decline in Older Adults 6 months post-discharge. We have Melissa Andrew contributing from Dalhousie University, George Cutchell from the University of Connecticut, our own Joanne Clark, and Robert Ole and Chris Voursure from HSNRI. We did a secondary analysis examining functional outcomes of patients who received multi-component geriatric interventions on medical units at HSN. This was Dr. McElhaney's original work. We asked a different question. We looked at, does ED boarding time affect functional outcomes at discharge and 6 months post-discharge? Our inclusion criteria was that they had to be admitted to a medical unit. They had to be a clinical frailty scale score of 4 or higher on admission. They had to be over 65 and under the care of a hospitalist. If they were under 65, under the care of their own family doctor or specialist, if they were a direct admit from home or a transfer, or if they were admitted with cancer, CVA, or mental health issues, they were excluded. We looked at Barthel Index, the HABM, and the Clinical Frailty Scale on admission, discharge, and 6 months post-discharge, and we used the Clinical Frailty Index to calculate baseline frailty. We had a total of 82 patients considered, 12 declined, 9 were excluded, and 1 patient passed away in the ED. We had a total of 60 patients to include in the analysis on admission and discharge, but only 50 participants at the 6-month follow-up mark. 6 were lost due to death, 2 were lost to follow-up, and 2 withdrew. ED boarding times. When we say boarding times, we mean decision to admit until transfer up to the medical unit. And we had a pretty even split. We had 28% or 17 patients who spent 0 to 12 hours boarded in the ED. We had 37% or 22 patients who spent 12 to 24 hours boarded, and we had 35% or 21 patients who spent over 24 hours boarded. And I do want to point out as well that over 24-hour group were statistically more frail on the clinical frailty scale. When we looked at the analysis as a whole group, everyone improved between admission to discharge. And then it looks like the whole group kind of maintained those gains. But we do have to keep in mind that that chart does not include those 6 patients, 10% of the patients who passed away between discharge and the 6-month follow-up. When we look at the results, when we analyze by boarding time, once again, all groups improved from admission to discharge. However, that over 24-hour group did not sustain those functional gains. There are several things that we already know from the geriatric literature are associated with functional decline and hospitalization. Those things are delirium, immobility, differences at triage, and overcapacity. However, there are other things that we think are contributing to this decline, and there's a reason why these patients are spending more time in the ED in the first place. When we looked at the Clinical Frailty Index and compared it to the Clinical Frailty Scale scores at admission, there was a greater difference in that over 24-hour group, which shows us that they had greater illness acuity when they came in. Often these patients present atypically, which we know, but it could be taking physicians longer to figure out what's going on with them and who is best to care for them and where should they go in the hospital. We also noted that those over 24-hour boarding patients had a greater likelihood of being admitted for chronic illness, infection, or social admission. We think multi-component geriatric interventions are effective. The study does show evidence of that. However, functional gains were not sustained in that over 24-hour group. They were more frail, they spent more time in the ED. Perhaps an earlier transition to a palliative approach to care might benefit those patients. This is the link to our full study. Thank you.